Muted.
Hello, I'd like to introduce Dr. Richard Lee, who is going to be sharing with us a webinar on strategic decisions in developing an integrative oncology practice, an academic perspective. Dr. Richard Lee is currently the medical director of the Integrative Medicine program at Case Western Reserve University. He is the inaugural Parker Hannafin Helen Moss Cancer Research Foundation Professor of Integrative Oncology. He also directs not only integrative oncology, but supportive oncology at University Hospital's Seidman Cancer Center, where he oversees clinical research and educational programs related to supportive and integrative oncology. He is also a medical oncologist who focuses on hepatobiliary cancer. Dr. Lee previously worked at MD Anderson Cancer Center, where he served as an associate professor in palliative care and rehabilitation and was the medical director of the integrative medicine program there. I will turn it over to Dr. Lee.
Great, thank you, Santosh, and thanks, Sarah. I'm going to be bringing up the screen here. So, as Santosh, I decided to change my topic a little bit today, and I thought it'd be more interesting to talk about mountain biking in California, something I love to do. So I hope that's okay with everyone, changing the topic a little bit. Now, it is April Fool's tomorrow, so don't worry, I didn't change the topic. We will be talking about developing an integrative oncology program and academic perspective. So let's move into the area here, and the talk is going to be about 30-40 minutes, and it's really going to be based on my own personal experience, both at MD Anderson and now starting a new job here at Case Western Reserve and University Hospitals in Cleveland, and thinking about building integrative oncology programs within a academic cancer center. And so I'm going to be talking about 9 different factors I think are really important for anyone to be looking at building a program. Now, let's see here. I just want to make sure, is everyone able to see everything okay? Hopefully everything's all right. So let's jump in here and look at these different factors, and then we'll have hopefully at least 15, maybe more minutes at the end to answer any questions about this topic. And the goal is to really give you some major areas for you to think about if you're starting your own program within a academic center. So let's just start with thinking about what's happening broadly, and this is a review of, some of you may have attended the workshop that Santosh organized at the SIO meeting in Boston. So just thinking about general trends in integrative medicine, and then we'll focus on trends within integrative oncology. So this is a report done by the Braywell Collaboration, part of the Academic Consortium for Integrative Medicine and Health. And they surveyed several different centers throughout the country. And you can see there are different models of integrative medicine programs. Again, this is more general integrative medicine, not specific to cancer, although it included some cancer centers like MD Anderson. Many are consultative in nature, some are more comprehensive, and others focus on primary care, which I think is probably the most common model. And over half of these practices actually provided inpatient services as well. If you look at what's actually being provided, the different practitioners that are employed, you can see here most commonly physicians, followed by acupuncturists, massage therapists, meditation, nutrition, and yoga, with the majority of centers having these practitioners. And they're serving a wide variety of patient populations, anywhere from adults down to OBGYN specific, end of life care, and pediatrics as well. You also see that there's a difference in terms of revenue sources. So depending on the practice, some may be more cash-based versus others might be billing insurance. You can see here really the only one that's billing insurance more is physician services. I am integrated medicine consultation versus most others tend to be a mix, some mostly cash, some a mix of cash and insurance. So, excuse me. So I think it's important to think about what's actually happening right now throughout the United States in different integrative medicine practices. The other thing it's worth noting is that there's really a development in terms of the name. So it used to be the National Center for Complementary Alternative Medicine. Now it's the National Center for Complementary and Integrative Health. Similarly, the consortium has changed their name recently to the Academic Consortium for Integrative Medicine and Health. And so I think we have to be very careful about how we name our different centers and understand that people are really moving toward that concept of integrative medicine and health. And I think moving away from kind of the term that we used to use of complementary and alternative medicine. And even within the big cancer centers, if you look at places like MD Anderson, just prior to leaving last year, the integrative medicine group moved into the Department of Palliative Medicine and Rehab. And then at Memorial Sloan Kettering, their integrative group has moved into the Division of Survivorship and Supportive Care. So I think that cancer centers are continuing to think about where does integrative medicine fit within a cancer center, and what does that look like, and who should they be aligned and partnered with. And so I think this is an important area as many cancer centers are dealing with this kind of question. So with that in mind, let's talk about some major areas or factors. I really thinking about the decisions, but I think really there are major factors you have to incorporate into your planning for an integrative oncology program at any kind of cancer center. So the first thing is really thinking about your assessing what's going on at your cancer center, and that's really what I've been doing for the last over 3 months here at Case Western. Is just really getting an understanding of what's here and what's happening. And I think there's a couple different perspectives you have to consider. First is the patient, and thinking about there's a dichotomy between what patients want and what patients medically need. And I think a lot of integrative practices, especially those in the community, tend to be focused on what patients want. However, I think when you're at an academic university that has a cancer center, I think it's more important to be focusing on what patients medically need. Okay, and sometimes they're the same and sometimes they're not, but I think it's important to differentiate the two areas. And then often is forgotten is not only what patients medically need, but what do the healthcare providers need in terms of improving patient care? What are the areas that exist that they don't have resources to access? So it's important to think about the healthcare providers as drivers of an integrative oncology practice. And really, I think when you focus on the healthcare providers as much as you do as the patient medical needs, then you'll find real easy wins in terms of where to target the oncology practice, integrative oncology practice. Think about the different perspectives. So as with any new developing field, there can be many different perceptions about what integrative medicine or integrative oncology is about. And so, it varies from alternative medicine and a very negative view to patients who are individuals, patients, and healthcare providers that are very positive. But I think you have to think about all the different perspectives and incorporate that, not just focus on the positives. What I find talking to other individuals is that when I visit centers, there's a lot of focus on people who advocate, but I'm as interested in people who advocate for the program as those who are critical. I'll talk more about that as well. So I think you got to understand and just have an honest understanding of perceptions. And as you go through this, I think you'll hopefully identify low-hanging fruit in terms of those areas that make the most sense for you to strategically expand into. So what you're really trying to identify is areas and gaps that exist that both patients and healthcare providers are interested in looking at. So the second topic or factor is really thinking about your institutional leadership. And of course, this can be very complicated as your institution, if it's a very, very large institution, especially if it's an academic institution. So really thinking about the mission and vision from the very top level down to where you may be situated at within your own department or division. So what is the mission and vision here at CASE? They have it labeled everywhere about to teach, to heal, to discover. So within that context, I think you need to know what is important to the institution and how does that relate to your program. Where does that fit within their priority level? And I think you just have to be honest with yourself. Most integrative oncology programs are not going to be in the top tier priority. But is it in the second tier, is it third tier, is it more of an afterthought? I think that's important to really understand your frame. And then what is the strategy of your institution in terms of its future goals? What are they focusing on? Are they focusing on technology? Are they focusing on healthcare change and economics? Because the more you can understand those priorities and strategies, hopefully you can align yourself within those, within a large institution. I think it's so important to understand the currency of your leadership. So I think a good example, I was in a meeting the other day, and we were going to generate reports for the Cancer Center leadership, and I asked, well, what do they look for in reports? And it wasn't really clear to me what's important or what the most focused commodity or currency is. So at MD Anderson, the currency in a lot of clinical activity reports is all about new patient visits. They were very, very focused on new patient visits. So if you create a report that doesn't have anything about new patient visits, you weren't going to have the currency that was critical to leadership. So I think it's important for you to know what the currency is that's most valuable and make sure you focus on those markers. And lastly, you have to think about who's ultimately making decisions regards to your program. Is it your division head? Is it your department head? Is it your cancer center leadership? Usually it's a multitude of individuals. And you may have different leaders who make decisions. So for instance, where I'm at, I have the medical school dean and a cancer center director who are very focused on education of the medical students as well as trainees and research. And then I have the president of the cancer center who's working for the university hospitals, which is the medical system, who's very focused on care delivery. So different leadership, different leaders will probably have different aspects they're looking at and will make decisions accordingly. So I think you just need to understand who are your direct reports and who's really making those decisions within the whole institution. So third factors, I think, is partners. Who are you really going to partner with within a integrative oncology program? And of course, if you're at a cancer center, you have to be thinking about your oncology partners. So, you know, in some situations, programs are being led by the integrative medicine program, and in other situations, it may be being led by an oncologist. So this is really geared to those individuals who are not oncologists but trying to build a integrative oncology program. Many times when I visit centers, they talk about, oh, you know, Dr. Rao is very supportive and he sends me patients. So that's great. You need to have colleagues, but you also want to have collaborators. And I look at collaborators as someone who's really working with you to say, design a program or to work on research, who will help recruit patients to your research project. Or, but ultimately, you really want advocates, someone who's not only just writing or collaborating with you on a research project or sending you a patient or two once a month for integrative oncology services, but really an advocate who's passionate about the field, who has hopefully some standing within the cancer center to be an advocate for you, and hopefully they have a leadership position. But that's what you really need. I think too often I find that people confuse a colleague who's supportive of integrative oncology as someone who's an advocate. And it's funny because when I meet with, because I know different oncologists, so someone will say, oh, I'm at this cancer center and Jane Doe is a huge advocate for my program, but I know Jane Doe. When I talk to Jane Doe, she'll say, oh yeah, I send patients once in a while. I think it's a nice program. And so I don't think they're differentiating their support at the same level as being an advocate. But you have to have real passionate advocates to grow a program within a cancer center. It's undervalued, I think, in many circumstances I've come across. Then you have to think about what relevant services. And now, of course, you're going to be working together with your local integrative medicine group. But I think it's just as important to understand where does your service fit within the context of care that already exists. So you might already have a palliative care department or center. You might have psychiatry, psychology, pain medicine. So where does integrative oncology fit within that area? Other services might be rehab and nutrition. And so you really have to think carefully about where your services fit within the context. And the landmine is to duplicate services. So, for instance, having a massage therapist who's already trained in lymphedema try to provide lymphedema services when rehab already does lymphedema. That would be a landmine and can really sink your program. So I think it's critical to understand who provides similar type services. How are you going to delineate your service different from these other services? Because you do not want to duplicate and compete. You want to be collaborating with them and make it clear how your service is distinctly different. And that is going to require a lot of meetings and understanding and really documenting, what is going to be done within your center versus not. And hopefully will inform your clinical pathways. Now, I don't know if anybody recognizes this guy, but this is from the movie Ratatouille, the Disney movie. If you haven't seen it, it's a nice movie, very entertaining. And this is the food critic in the movie. And so I bring this up because I think it is really important to know who your food critic is at your institution. Again, what I find is that people tend to just disregard or ignore the biggest critic. My approach is I want to know who the biggest critic is, and I want to meet that person and understand why they're a critic of integrative oncology. And you can't dismiss this at all, because oftentimes the biggest critic is someone who's actually very senior, very well known, and people well respect. And so if you don't address the criticisms being brought to your program, it'll be a major hindrance to your progress. So I seek out and address the critics and engage them in a dialogue. And my experience has been they actually generally have very good, valid criticisms of integrative, or really what I would call alternative medicine. And I think you just have to be aware of them and address them head on so that when your biggest critic starts to accept what you're doing, people will realize that, and it'll be a big boost to your program. Now, I'm not going to spend too much on the financial aspects. I know that Santosh has got the next talk really focusing on the financial models. I'm just going to bring up some quick issues here about you have to think about sources of revenue. Of course, the revenue will be coming from your hospital, hopefully, maybe, maybe not. But also you have to think about external resources of funding through grants and philanthropy or through nonprofits or generous donors. But think carefully about your revenue model. And that oftentimes is going to be a mix of out-of-pocket insurance, bundled care, or even free services, which we did provide and we plan to provide here. So I think you won't be able to grow without having some kind of strong business model. And it's probably going to evolve over time where initially you're really dependent on grants and philanthropy, but hopefully can move to a revenue-generating model. So again, I'm not going to spend a lot of time on that, and I'll leave that for Dr. Rao's presentation. Staffing. So really there's two categories of staffing you have to think carefully about. I think you've got your clinical staff, those who are really connecting with patients, so medical assistants, nurses, advanced practice practitioners, and then I think also about integrative practitioners. You can see here that I'm using a very medicalized model where we have the standard clinical staff that you would find in any disease center clinic here at the Cancer Center. I think the only thing that's differentiating us is the type of practitioners, integrative practitioners that we have. And then, of course, you've got to have your support staff, administrative assistants, patient care coordinators. You can't underestimate the importance of a business manager and a program manager if you hopefully can have that as part of your team, or at least maybe borrow the time of somebody who can help you with the programmatic issues and administrative issues of really coordinating a large team. So very important part of your whole team that you've got to bring together. And then as you interview, and I'm in the process of building a team here and interviewing potential for these open positions that we have, it's critical to think about what are your core values and philosophy of your program, the clinical model. I think in academics, and we'll talk more about, it has to be evidence-based and has to have research. And in integrative practitioners may or may not agree with this. And so I always, at every visit when I'm interviewing integrative practitioners, tell them up front, the approach is totally science-based. You have to engage in research. And if you're not comfortable with that, that's absolutely okay. This is just not the right fit for you. Okay, so I tell people up front what the expectations are, because there has to be alignment in these areas. And any type of hesitation for which you think there's not going to be long-term alignment, I think you're just not a person you want to be working with, because I've been there and I've been in situations where I've had questions about alignment, and I would say more times than not, it just doesn't work. And it's a struggle for both sides. So really think about alignment of your staff very carefully. The other thing I'll say is that because I'm in an academic center, I have a lot of candidates who are very into what they call holistic or integrative complementary alternative medicine. And they're extremely passionate, which is great. But to some extent, they're so passionate that they ignore the evidence and research and the academic nature of what we're trying to build. And that actually, what people think is a perfect fit on the outside, to me, is actually going to end up in conflict. So I'd rather go with somebody who has less experience but is committed to things like research and evidence-based than someone who's really committed to integrative medicine but not really to the research or science. That I hold to a higher importance when hiring staff. Logistical support, so these are just the things that have to be worked out before you start your program. So I recently had some conversations where people, let's just get started, let's throw a massage therapist into the center. And I said, well, I'm not so sure. Do we have the right rooms for the massage therapist? Do we have the right equipment? So these are all the kind of things that have to be worked out. You can't just have the massage therapist show up. Does my massage therapist have access to my EMR? It's kind of fuzzy because the EMR system here isn't that great. But hopefully you have a better EMR system. But they have to have access. They have to think about all these issues. And then how are you going to market your program? Who's going to know about it? And then once they know about it, how are the referrals going to come? So I think there's so many logistics, including, I'm not even talking about the billing here, that have to be worked out before anyone shows up to be providing services. Do you have standard operating practices, consent forms? What are your safety guidelines? So all of these kind of logistics have to be clearly laid out before the first patient shows up for the clinic. So, and that will likely take months of planning to make sure everyone's on the same page. So education. At an academic institution, most they're going to require some kind of educational component. I think the first step is really educating the healthcare professionals, physicians, nurses, advanced practice practitioners, and making sure your colleagues understand what your service is, who should they send, who should they not send, and how do they refer. Then it's also about educating patients and the general public. Now, I should emphasize the importance of making sure you have the right team member for the right audience. I've been in situations where we had non-clinical staff present to a group of nurses or physicians even, and that usually will not go very well. I always try to match the speaker to the audience. So when we have a advanced practice practitioner meeting, I'll usually speak together with one of my own advanced practice practitioners. When I'm talking to nurses, I bring along one of my nurses. So you got to connect with the audience. You got to make sure it's the right message. And I would not confuse this with marketing. Marketing is one thing, education is different, and you don't want your educational talks to sound like marketing. That, I think, is another disaster waiting to happen, because healthcare professionals especially do not like marketing. They want education, and it has to be science-based. So think about that very carefully. And then, of course, you have to educate trainees, nurses, medical students, and such. I think that's difficult and something usually that I think about later on after a practice has been developed, but an important part of your planning long term. So let's talk about research. So again, any academic university has to have research. Now, many of you may be thinking, well, why do I have to do research? At a minimum, whether you're at an academic institution or not, you have to be doing tracking data, okay, that documents benefits. And so if you don't think about tracking data about your program, you're going to end up in trouble in 2 to 3 years when leadership starts asking what impact you're having. Now, the easiest is financial, but oftentimes integrated programs are not robust revenue generators. So you also have to think about cost savings. Are patients who see patients, let's say, in the inpatient, spending less time in the hospital? Are they utilizing less resources for pain management? How are you improving patient care? Are you documenting outcomes, patient-reported outcomes? Maybe improvement in patient satisfaction. And is your program a market differentiator in your region? So I think there are a lot of different outcomes that you can be monitoring, but you have to be monitoring outcomes from the beginning. And not doing so, not planning to do so, will reduce your own growth. I do believe, academic place, you got to be thinking about clinical research, and so thinking about what kind of clinical priorities you're going to have in this area. And ideally, this is really the currency of any major academic university is, are you engaging in basic and translational research? That's where I think the scientists really, you can see they have much more respect for a program that is looking at, say, genomic analysis of patients who respond to certain therapies. Are you doing some translational work that really understands the mechanism of, say, acupuncture or meditation? So I think to be at a top-tier program, you have to be doing this level of work and thinking about who you're going to collaborate with and who your partners in this area. So ultimately, this should all lead into to this final area, which is all this information you have to bring together and think about what is your mission, vision, and clinical model and philosophy. I mean, this is really the crux of your program and the foundation. And within integrative oncology, there's really two major challenges. One is thinking about level of integration, okay? Another is really how medical or oncologic you're going to be. And so this is really, are you going to fit in to a system of care, or are you going to be the outsider who people refer you to but isn't really part of routine care at your medical center? And I can easily say 90% of programs I've run into, integrative oncology programs I've run into, are really secondary. They're not integrated at a fundamental level. And if you look at successful integrated medicine programs, many of them are housed within family practice, primary care. And they make it part of primary care visits. So I think that you really have to figure out, where does integrative oncology fit within your center, and how is it going to integrate with other services that exist? For instance, here we're really looking at integrative oncology as part of supportive care and the whole spectrum, and really creating a unified, cohesive program of palliative and integrative clinical service. So there's no separation. Really, it's just one major team that helps with symptom management, quality of life, and incorporates integrative therapies. It's not a separate service. Is what we're planning to do. And secondly, how medical are you going to be? And I think that most programs tend to be very limited in this area, and I think the more medicalized you are, the more you look like any other clinical service within the cancer center, the more accepted you'll be and the more successful you'll be. And that requires, of course, research, and not in addition to the clinical services and also education. So I think you have to think about that model. And so, as you look at different models, there's really three major models, right? The alternative, complementary, integrative. If you're at an academic center, you're likely not to be alternative. I just show this to show the two extremes, which is, they're really anti-medicine. Don't practice evidence-based care, mainly cash, and really do almost no research. And what you don't want to have is somebody on your team who's really alternative. That is the Achilles heel for your program. Now, most programs are probably here, which is a complementary, where they're more neutral about conventional care, and maybe incorporate some evidence into their practice. They're mixed cash insurance, and are found at many cancer centers, but really are down the street or not really integrated, and do some research, but not really writing grants. And I think the integrative model is going to be one where you're really indistinguishable from any other clinical service. You are an advocate for conventional therapies because they are part of optimal cancer care, along with the incorporation of other supportive and integrative therapies. Strictly evidence-based, likely depending on mix of cash insurance, philanthropy, integrated into the system, and actively receiving external grants from NIH and other nonprofit organizations. All right. You also have to be thinking about your clinical model, so it's clear to others where does integrative medicine fit. This is a clinical model that was developed at MD Anderson, but I can tell you right now I'm in the process of creating a new clinical model for here at Case Western. It's still in development, and it's going to be tailored to the situation here. So, but it is critical to have this kind of model created. It's critical to have your core values and principles clearly laid out so that everybody understands what you're about and how you can help with patient care and really contribute to the cancer center. So in summary, we've got, you have to assess what's happening within your institution. What is the leadership focused on? What is their priorities? What is their strategies? What's the currency that they use to make decisions? Identify your partners and critics. Don't ignore the critics. Think about your financial model, which Dr. Rao will talk about more next month. Staffing, and really remember alignment is a critical piece to building your team. Logistics, education. Again, education is distinctly different than marketing. Education at all levels. Thinking about how you're going to incorporate research, and at a minimum you have to include outcomes research about your impact of your program, and hopefully all of those will naturally fit into the mission, vision, clinical model, and philosophy that you develop. So it's really, you have to take input from all these different areas to find one that is a right fit and that will resonate with your institution, and that will help you grow and develop. So I'm going to stop there. It's about, we have about 20 minutes, and then we'll open it up for questions. So thank you, everyone, for your attention and joining us today, and I appreciate Sarah and SIO for hosting this, and for Dr. Rao for moderating. I'll stop there.
Thank you, Rich. We're still awaiting questions from the attendees. If anybody has any questions, please send them in. I'll start. Rich, you have been, now you're director not only of integrative medicine, but supportive oncology, and at MD Anderson, you were part of the palliative care program. Can you talk a little bit about how that might serve as a model in other institutions for integrative oncology to be aligned with palliative care and the concept of supportive oncology in that regard?
Hey, Santosh, sorry, could you repeat that question one more time? I'm sorry, I just missed the first part of it.
Well, just basically the concept of supportive oncology as a model for integrative oncology moving forward, that to align ourselves with palliative care and in an academic institution.
Right, so in my perspective, that most of the integrative therapies are really aimed at symptom management, quality of life, and improving health. And I really put the use of, say, like herbs and supplements, which is a mainstay of many integrative oncology programs. I look at that as more medicine, more drugs. So I separate that intentionally. So if you remove that aspect of care, then all these therapies are really focused on helping the patient, supporting them through treatment. And there's a lot of needs generally because of the toxicity and the side effects from cancer and and its treatment. So to me, that's where the natural fit is, to help patients manage symptoms, reduce stress, and really focus on their overall health. There is a small component of my practice that might be utilizing what we would consider alternative therapies, but that's a very small portion, and using, say, herbs or supplements in a anti-cancer approach, but that's such a small, minimal component. It's not, to me, a really significant aspect. And I think, as an oncologist, it should only be done by oncologists, because you really understand how those types of approaches are experimental and where they fit in within a cancer treatment plan. So that's why I think the 90% of what integrative oncology is about is really about supportive care and fits within that model.
Great, thank you. I'm just getting some questions now, so let me ask some of them. One person asked if you could show the MD Anderson clinical model again and speak about how you might modify this model in Case Western.
Yeah, so, if you think about the model, I think the model here is somewhat out of proportion. So if you think about, if you haven't read Sidney Farber's article on cancer from 1965 about total care of the patient, it's probably a really good article for someone to read about. And Sidney Farber really talked about, what does it mean to take care of a cancer patient in his entirety. And I think that this model is not balanced in the sense that, half of what we're doing is really treating the cancer, and the other half is supporting patients. So I don't think the model accurately demonstrates that. So I'm kind of in the process of reworking this. So that's one of the aspects I'm thinking about. Other aspects are, as you can see here, at MD Anderson, for instance, they already had pain center, supportive care center, cancer prevention, and so that's not necessarily, really we have no tobacco treatment program here. So clearly my partners and how I'm going to integrate into the system is vastly different just by being here at Case. So I think that the components are here, but really in terms of the schematic and how I represent them, I'm changing that. So yeah, and it's kind of vague because I haven't really defined what that clinical model is going to be now here, but it's basically because I need to modify according to where I'm at, but it'll continue to have a lot of the same main components.
Okay, we're getting a lot of good questions. Another question is talking about barriers to developing a program and the resources that are needed. What are some of the barriers you're finding in initiating and keeping up a program like an integrative program?
So barriers, well, I think there are probably different types of barriers depending on what stage of development your program is at. If you're starting a program, there is a slew of barriers, from financial to education, making sure people understand what's ongoing, and trying to just team build. I think all the aspects that I talked about are things that are actively ongoing for myself right now. And to be honest, I'm not so worried about the critics because in many ways they are correct in what's wrong with a lot of integrative programs that exist. So I think that the model, will naturally address a lot of the common criticisms. So I think it's hard to know and to build partnerships that are long-lasting and genuine. I think that's part of, because many services may see you as a threat, And so I think you have to quickly demonstrate that you're focused on patient care and not looking to duplicate services. And so that people will want to partner with you and understand that through partnership there's a synergy and that both services will ultimately succeed and grow. And it's not about taking patients away or trying to compete for those patients.
Great. I have another question. Did you notice new configurations since the mid-1990s with the creation of NCAM and with the creation of OCCAM at the NCI, basically looking at support for integrative oncology from a research perspective, administrative perspective?
What's the question again, Santosh? Is there a reconfiguration of?
Did you notice a change in, did you notice new configurations since the mid-1990s with the creation of NCAM, NCCIH, and the creation of OCAM at the NCI? I think what the questioner is getting at is within an academic center, has this allowed integrative oncology to align in different ways with support from an academic perspective or support in terms of the academic model? How has this changed how integrative oncology is viewed? That's how I read the question.
Yeah, that's a good question. I'm not really sure. I think that if you look at the NCIH and OCAM, I think their priorities have changed over time and what they're focusing on. And so I think it's important to understand what those priorities are from the NIH and try to align your own program to those priorities and focusing on good science. I think that over time, I think the bar is getting higher in terms of what is considered good science and understanding mechanisms and really delving into those therapies that are likely to be the most beneficial in patient care. That's my sense of it, but that would be something where I suspect a lot of people have different opinions about.
All right. Next question is from one of the co-chairs of the 2016 SIO conference in Miami. So I hope to see everybody there. He says it's important that we add value to community organizations. How much importance do you give to a formalized organizational chart in order to streamline communication strategies towards this end?
So so I totally agree. Hopefully everyone on this call knows about the meeting in Miami. I think it's going to be fantastic and focusing on global issues within integrative oncology, so very excited for that. So good, thank you for bringing that up. So the question being about, is it focusing on
community organizations, how to align and with community organizations, how much importance do you give to a formalized organization chart to add to show that we have value?
Right, I think it's very important. I can tell you that there's
not just community organizations, but to the organization in general.
To the organization in general. I mean, I think you got to have a kind of organizational chart, and you have to have outreach to the community. And I can tell you here at CASE, there's a very strong program called the Gathering Place, and we are planning to partner with them very closely, especially in patients who are in survivorship, because it's a great resource that already exists. So I think when you can, partnering with community organizations, making that provide input into what we do here, providing out to every area. So you have a component to your program.
Another question is, if somebody's just starting, how might you decide what to start with? In our particular integrative program, we have decided to maximize one modality before adding more, just so that we had practitioners used to the idea of their patients getting acupuncture, for example. How do you make those kind of decisions, and how much is it based on the patient population, the community that you live in, and what you think might be more evidence-based and easier to apply within a certain institution?
Yes, I think that's a very good question, and therapy. So I think you've got to take in the different components, as we've talked about already, everything from what currently exists in terms of assessing what's your low-hanging fruit, what is the model that's accessible there. A model in California will likely be very different than a model, say, in Iowa, right? So you're going to have to think about the current perspectives, what might be covered by insurance. I know a lot of things are covered on the West Coast that wouldn't be covered here. So all of those factors play a role. I do like the approach of a focused one or two services to get things going, to get traction. I've seen the mistake of programs offering a dozen services, and what happens is you have great services that are evidence-based, like acupuncture, meditation, nutrition, but you're combining them with something like, say, Reiki or medical Qigong or energy healing or homeopathy, all of which have very little data. And those programs will be the Achilles heel. That will basically kill all the other evidence-based approaches because you're putting them all together. So I think it's, when I was at Anderson, I got rid of some things because I just said it wasn't worth it. It wasn't worth the negative damage, and it was going to bring down the whole program, in which it had in many ways. And by eliminating those controversial areas, the major critics couldn't be critics anymore because we got rid of them. So what were the critics going to say? So I think you have to think about those things very carefully.
Great. The next question is about where to start, and somebody asks if there is a prototype integrative oncology development course or other practical guideline references for these services within an academic cancer institute. And I'll just add, somebody other than what we're providing at SIO, how might somebody get mentorship in really designing an integrative practice?
Yeah, that would be great. If so, I know that you can go to different programs. So, like, you can go to Memorial Sloan Kettering and visit, and I think there's a fee, and they'll provide you, advice about your program and how to get it going. MD Anderson, where I used to work, had a workshop. It's like a 2 to 3 day workshop where you can learn about what we do, although it doesn't. It just tells you about what they're doing rather than giving you advice about your specific, what you should do within your own specific institution. And I know, like at SIO, Dr. Rao had a workshop specifically on this kind of topic, and I think SIO's had different workshops in the past. Outside of that, and then I think Glenn Seidman has he's a consultant. I forget the name of his company. Fawn Therapeutics, and I think he provides consultative services. So I think there are a couple outlets out there that exist and can be utilized as resources. Santosh, do you have any other suggestions of other resources that exist?
No, I think you're right. I think that SIO, this is one of the missions that we have within SIO, is really to help people, and that's why we're providing these webinars, and we want to provide more content. And I think it's partly developing that content and hopefully in the future having more strategies for training or for guidelines. And then I think one of the other benefits of SIO is providing that network where you can meet people like yourself who can really give you that firsthand information.
Yep.
So we're getting short on time. I'm just going to ask maybe one or two questions more, if that's okay, Rich.
That's fine.
One question is on volume, and there's many people who've asked questions about volume. Why don't we have more volume in integrative oncology compared to the cancer center as a whole? And if we align ourselves with palliative care or with survivorship or any other part of cancer care, are we potentially going to limit our volume to those patients who are at end of life care, who are really overlapping with that particular cancer service? How do we kind of get out of that box and maximize volume?
Yeah, so this is a good question, and I think let me address the second part of that question, which is, are you going to limit yourself by associating with palliative care? I mean, palliative care as a whole is moving toward treatment at the beginning of, or interactions at the beginning of treatment from diagnosis. So although I know palliative care is usually associated with end-of-life care, hopefully, the palliative program you're working with is part of the movement to move palliative care at an earlier stage. So, and then I absolutely do not think that you're limiting yourself, because a lot of what palliative care has done is where integrative oncology is at. So if you look at the trajectory of palliative care to where it is now, say from 20 years ago, I mean, it's made a huge leap forward. And really every cancer center, I mean, I can't think of a cancer center who doesn't have some kind of palliative care program. But I can still think of some cancer centers that really don't have an integrative oncology program. So I think your allies in palliative care are there, and they're great allies. Speaking as someone who's trained in palliative care. And there's a lot of overlap. So think about the synergy. You're not limiting or you're not competing. It's, integrative oncology and integrative medicine in general has problems with integrating. And so you need to find your partners that are already integrated and grow from there. In terms of activity, so, I find this very interesting, because I know a lot of people will say to me, well, every person should be getting integrative. And actually, I don't think that's true. Okay, it's kind of like a palliative care doctor who says, well, everyone needs palliation. Yes, that's true. Okay, but not everyone needs to see a palliative care doc. Physicians, nurses, advanced practice practitioners can manage a lot of simple things like pain management, adjustment disorder, anxiety. So not everybody needs to see a palliative care doc. Not everyone needs to see an integrative care practitioner. So if you focus on patients with real medical needs, okay, that aren't being adequately addressed by the current system, then you're probably looking at a touch rate of somewhere between this is just my own personal guess estimate, okay, and it's probably somewhere between 10 to 20%. And I'll tell you how I come to that number. So if you look at the data of people who are using complementary alternative medicine modalities, okay, through the CDC, adult Americans, it's somewhere about 30%, and in the past 12 months. And depending on your population, if you're at a tertiary center, that might be a little bit higher, okay. Majority of these are people who are using herbs or supplements, okay. So if you take out the herbs and supplements, and many are just taking calcium or vitamin D or something, then you're getting down to, say the 10 to 15% range, okay, of people who are utilizing these services. So if you just look at that population, well then that would only be 10 to 15% of the patients who have an interest or have utilized these kind of things. But you have to remember, some of these patients probably didn't need to be using these therapies. Often it's the worried well, right? And then you have to think about, well, what are those patients who don't know about integrative services that actually need it? So that's why I kind of put the range as somewhere of 10 to 20% of, say, patients coming into your cancer center system that may actually benefit from an integrative service. So that, to me, if you were reaching a penetrance of your service of, say, 10%, that's probably pretty good. If you got to 20%, that would be really great. I don't know of a program that has that level of integration, but I think it's possible. And aligning through other services like palliative care, supportive care services, I think is one way you could achieve this.
Well, thank you, Rich. This has been a great talk, and I hope that everybody shows up for the second part of this talk, which I will be giving on May 26th on more of the financial aspects of designing an integrative practice. I did not get to all the questions. There were a lot of other great questions, but in the interest of time, I think we will end this webinar at this time. And thank everybody for coming.
Great. Thank you, Santosh and Sarah and SIO, and thanks everyone for your attention.